video start first. So should we start? Are you in the class? Other people are in the class? Hello? Are you listening? Hello? Assalamu alaikum. Are you in the class? Should we start? Okay, should we start? So today we are going to start the management of the normal labor. Okay, so it's very important. There are some certain dummies and the models. We will discuss on the dummies. I will show you. That's why today I start the video. That I will show you the model of the pelvis as well as of the fetal head. So by looking at the model of the pelvis and the fetal head, you will understand very clearly. So what we are going to do in this today's class is what is labor, what is mechanism of the labor, what is the management of the, what are our aim in the management, aim and principle in the management of the labor. So by definition, if you are going to define the labor, how we define the labor, it is a regular painful uterine contraction associated with the cervical effacement and the dilatation. या इसको आप इस तरह से भी कह सकते हैं कि regular frequent uterine contraction, any uterine contraction which is associated with the certain changes in the cervix, then it is known as then we can label it as a labor. If there are the uterine contraction could occur in the pregnancy that are known as the Braxton Hicks contraction, they may be painful or they may be the painless, but along with the uterine contraction, there is no change into the cervical effacement or dilatation. There is no change in the cervix. But if along with the uterine contraction and there are the regular coordinated का मकसद ये है कि एक के बाद दूसरी, there is a short period of pause followed by the uterine contraction, and along with the uterine contraction, there is a certain change in the consistency, certain change in the dilatation of the cervix, effacement of the cervix, then you can label it, this is the patient in the actual labor. So painful regular uterine coordinated uterine contraction associated with the cervical dilatation and effacement followed by the expulsion of the product of conceptions or the delivery of the fetus. Expulsion of the product of conception का मकसद है fetus and the placenta. So the delivery of the fetus and the placenta. So regular uterine contraction associated with the cervical effacement and dilatation leads to the delivery of the fetus and the placenta is known as the normal labor. This is the normal labor. This is the definition of the normal labor. If you are going to say the normal labor, it means that the cephalic presentation and the gynaecoid pelvis. So there are for the normal labor, there are the three things which is very important. That is the passage, the passenger, the power. The passage is what we mean by the passage. Passage is the maternal pelvis as well as the maternal vagina, the uterus, cervical canal, vagina, all these are the passages. What we mean by the passenger? Passenger is a fetus. It could be the fetal head, it could be the fetal shoulder or also fetus. Now what is the power? Power means uterine contraction. So for the normal labor, the passenger should be in the normal attitude. The passage should be adequate. The power should be adequate. That's why the normal labor will be occur. Otherwise, the labor could be abnormal, it could be the prolonged, it could be the obstructed. So, by staging, the labor is divided into the first stage, the second stage, and the third stage. The first stage is again divided into the latent phase and into the active phase. Now I'm going to show you, this is the passenger. Passenger means the whole of the fetus. This whole fetus will be delivered by the normal vaginal route. And this is the head of the fetus. So if you are going to discuss, we are going to discuss the normal labor, means when the head is in the cephalic presentation or the vertex presentation. And then the passage is the one of the important passage is the fetal pelvis. This is the fetal pelvis. Now first we discuss the fetal pelvis or the passage. So the pelvis is divided into the two parts, that is the false pelvis and the true pelvis. Why we call that the portion above this pubic, what we say that the iliopectineal lines is above, the portion above this is known as the false pelvis, and the portion below is known as the true pelvis. Now in this true pelvis is again divided into the inlet, the cavity, and the outlet. Now look at the pelvis. When anybody, any human being stand on the floor, the pelvis, the angle of the pelvis is not a right angle. It is a 60 degree. 60 degree पे ये क्यों होता है? Okay. Now the pelvis inlet, the boundaries of the inlet are the anteriorly, the upper portion of the pubic symphysis, then the pubic tubercle, and then iliopectineal line. This is the iliopectineal line, then the ala and the promontory of the sacrum. So this form the boundaries of the pelvic inlet. Pelvic inlet anteriorly, again anteriorly upper portion of the pubic symphysis, the portion of the pubic ramus, iliopectineal line, the ala and the promontory of the sacrum. Now this inlet is the transversely oval. It is a transversely oval, and its transverse diameter is 13.5 centimeter, while the AP diameter is 11.5 centimeter. So this is the transversely oval. The transverse diameter is the largest diameter of the pelvic inlet. Then there is a cavity. If you are going to, I am going to show the cavity. This is the middle portion of the pubic symphysis. Then the obturator membrane. Inside the obturator, this is the obturator foramen, and inside the obturator membrane, and laterally there is this sacrospinous ligament. The ligament which is extend from the ischial spine to the sacrum, laterally the sacrospinous ligament, and posteriorly the second and third piece of the sacrum. So this cavity is a round, and it is because it's a AP as well as the transverse diameter is equal. It means 12 centimeter. The AP diameter is also 12 centimeter, and the transverse diameter is 12 centimeter. So it is a rounded. Then there is a pelvic outlet. The outlet is a outlet. This is an outlet. This is an outlet. It is a diamond shape. It is a diamond shape, and anteriorly it is bounded by the lower portion of the pubic symphysis, the rami of the pubis, and the ischial tuberosity, sacrotuberous ligament. Laterally the sacrotuberous ligament, and the posteriorly the last piece of the sacrum. So the AP diameter of the outlet is 13.5 centimeter, while the transverse diameter is 11. This is just opposite to the inlet. Means AP diameter of the outlet is larger than the transverse diameter, while in the inlet the transverse diameter is larger than the AP diameter, because the head is delivered into the AP diameter. Now this is the AP diameter 13.5 and the transverse diameter is a 11.5 centimeter. And this is because the head is delivered into the this. Now after the passage, and then there are soft tissue like the uterus, the cervix, the cervical canal should be dilated. The perineum should be not rigid because there may be the chances of the perineal tear. So this is also the part of the passage, but the important part of the passage is a bony passage. Then after this pelvis, this is a passenger. The main, again in the passenger, it is a fetal head, which is important. While remaining of the portion of the fetus is the soft and can be easily passed. There are certain terminologies which is very important in the fetus. The attitude. Attitude means the relationship of the different part of the fetus with each other, like this. The fetus is normally in the flex attitude, means the hips are flexed, the legs are flexed, the arms are the flexed, and as around the chest, and the head is flexed. So this is known as the flexion. Flexion is the attitude. It's a relationship of the different part of the fetus with each other. Then the lie. Lie is the relationship of the long axis of the fetus, long axis of the fetus with the long axis of the mother. मदर का जो लॉन्ग एक्सेस होगा उसके साथ जो फीटस का रिलेशनशिप होगा दैट इज द लाई, उसको लाई कहते हैं. ये इस तरह से, अगर ये इस तरह से बच्चा है, फॉर एग्जाम्पल इट इज अ लाई longitudinally, means long axis of the fetus with the long axis of the mother, then we call it is the longitudinal lie. But it could be the oblique, it could be the transverse. So the lie could be transverse, it could be the oblique, it could be the longitudinal. Normally the normal labor के लिए longitudinal lie and cephalic presentation is a portion of the fetus which is with a relationship with the pelvis. Like if the head is coming in the lower uterine segment, then it is known as the cephalic presentation. If the breech like this buttocks come into the lower uterine segment, then we call it the breech presentation. In the transverse lie, it is a shoulder presentation. Oblique or transverse lie, it is a shoulder presentation which is coming. So the portion which is coming into the lower uterine segment at the time of the labor and have the relationship with the pelvis, then it is called as the presentation. Then in the head, there are certain landmarks which is also important for understanding. Are you able to see? So this is the head, fetal head, and there are certain suture lines. There are certain sutures lines. So in the vertex or the head, there are the vertex is a portion of the head which is bounded by the anterior and the posterior frontal and two parietal eminence. These are the two parietal eminence, and this is the anterior frontal, and this is the posterior frontal. This is the posterior frontal, this is the anterior frontal. So the area between the anterior and posterior frontal and between the two parietal eminence is known as the vertex. So we call the vertex presentation by when we are doing to this vaginal examination. We call this is the vertex presentation. Now this head is having the sutures, and there are the sutures that are the important sutures are the sagittal sutures, the coronal sutures, the frontal sutures. Sagittal suture, this is a vertical suture, this is a coronal suture, this is the frontal suture, and this posteriorly, this is the lambdoid suture. And there are certain spaces which is the bone-free spaces, and these are covered by the membrane, and these are known as the fontanelle. There are the two fontanelle in the fetal skull, anterior fontanelle, which is a diamond shape, this is a diamond or kite shape, and the posterior fontanelle, which is a triangular shape. This is a posterior fontanelle, small posterior triangular shape fontanelle. And the area behind the posterior fontanelle is known as the occiput. This area behind the posterior fontanelle is known as the occiput, and area anterior to the anterior fontanelle is known as the sinciput. This is the sinciput, and this is the occiput. Now, why we are, I'm going to show you all these things, because in the normal labor, it is a vertex, which is a presentation which we feel by the vaginal examination, and it is an occiput, which is a normal position. Either this occiput is an anterior, means this means this. When we call the occiput anterior, means the posterior forenail faces to the pubis symphysis. Then we call this occiput is anterior. Like this. This is a posterior forenail, and now like this. This is a occiput. This is a occiput, and this is a posterior forenail which faces to the pubic symphysis. And the anterior forenail faces to the sacrum. Then we call it is a occiput anterior. Now this is a direct occiput anterior. This may be it's set in 45 angle, right side or into the left side. So why we call it the occiput? Because this occiput is a denominator. This denote the position of the fetal head. Now there are certain diameters which are very important to understand. The one diameter which is very important for the length. Normally in the normal labor, there is the diameter which is present into the pelvis, maternal pelvis, is suboccipitobregma. Bregma area of the anterior forenail को कहते हैं. Bregma is the area of anterior forenail. So suboccipito, below the occiput to the anterior forenail, this diameter is about 9.5 centimeter, and this is the normal diameter, and this diameter is present at the time of the normal labor. So if the diameter is a larger, either the labor will be prolonged or it may be the obstructed. Then there is a certain other terminologies, that is the molding. Molding means overlapping of the bones over each other at the suture lines. For example, this may be the parieto-parietal, this may be the parieto-frontal. So if the suture line apart, then it is a 0, approximate 1, overlapping with each other is a 2, but easily separable. Overlapping with each other but not separable is molding 3, and molding 3 is a sign of the obstruction, and it should not be occur normally. The patient go into the prolonged, then the molding will be the grade, it may be 2 or 3. Now going to again to this presentation. Now this is the normal, the first stage of the labor, second stage of the first stage start from the dilatation, onset of the labor to the with the onset of the labor with the full dilatation of the cervix. Now the dilatation of the cervix, the first stage is divided into the latent phase, it is the active phase. The latent phase starts from the 0 to 4 centimeter dilatation, while the active phase starts from the 4 to 10 centimeter, and 10 centimeter dilatation is the full dilatation. Now this is the first stage of the labor. Stage 1, this is still just there is a dilatation. What we mean by the effacement? Effacement is the absorption of the cervix by the lower uterine segment. For example, and we categorize it into the percentage according to the length of the cervix. The normal length of the cervix is 3.3 to 3.5 centimeter. So if we say that the cervix is 50% effaced, means 50% cervix has been absorbed by the lower uterine segment, and means the cervix is about the 1.5 to 2 centimeter in the length. Then for example, in this diagram, you can see that this is the uneffaced cervix. Cervix is still not effaced, but there is certain dilatation. This is the vagina, this is the cervix, this is the lower uterine segment, and this is the fundus of the uterus. Now, in this picture, there is a full dilatation with a full effacement of the cervix. You cannot able to see the cervix, the portion of the cervix. So there is a full dilatation. So first stage starts from the cervical dilatation up to 10 centimeter. And the second stage starts from the full dilatation to the delivery of the fetus. Look at this, there is a full dilatation of the cervix and the baby is going to deliver. Now the third stage is the delivery of the placenta and the membrane. After delivery of the fetus, along with the delivery of the placenta and the membrane, and this is known as the third stage. The duration of the first stage is a variable in the primary gravida and as in the primary gravida and into the multigravida. In the primary gravida, this is the duration of the latent phase is a very variable, because patient may in the multigravida patient may be into the 3 or 4 days in the latent phase. So we can call it because there is a multifarious house. So we cannot easily categorize the first latent phase of the first stage into the multigravida. While in the primary gravida, if there is a certain change, you can say that the patient is in the labor. The signs of the labor otherwise is the painful uterine contraction. Either there is a regular coordinated painful uterine contraction, cervical dilatation, cervical effacement. There is a mucus plug which is separated from the cervical os, that is known as the show, which is contained with a stained with the blood. This secretion is stained with a certain amount of the blood, that is known as the show. Or sometimes the patient may present with a rupture of the membrane. So there is a gush of the fluid, gush of the water or the gush of the fluid. This is also one of the signs of the labor. Now the duration of the first stage in the primary gravida is a 10 to 12 hours. It should not be more than 12 hours. While in the overall जो duration कहते हैं labor की 12 hours होनी चाहिए primary. It is 6 to 8 hours in the multigravida. So the 4 to 6 hour first stage, 4 to 6 hours second stage. The latent phase and active phase. The second stage, the duration of the second stage, if the patient has no epidural analgesia, then it is a 2 hours in the primary gravida, 1 hour into the multigravida. But if the patient having the epidural analgesia or the anesthesia, then this duration may be increased, because the epidural analgesia and anesthesia may delay the second stage. So it could be the 3 hours in the primary gravida, it could be 2 hours in the multigravida if the patient having the epidural analgesia. Third stage, the duration of the third stage is half hour in both the primary or आधे घंटे में प्लेसेंटा का आउट होना बहुत जरूरी है. If the placenta has not been delivered within a half an hour, you can label it as a retained placenta. So we will continue the mechanism of the labor. Now it's a very important. It's a picture show you that the pelvis with a cephalic presentation with an occipital interior position, because you can see this is a the occiput, this is the occiput, and this is a sinciput, because posterior forenail faces to the pubic symphysis and the occiput is just behind the pubic symphysis, so we call it the occipital interior. Now occipital, this is the left side and this is the, so this is the left occipital interior. This is not the direct occipital interior, but this is the left occipital interior position. It is a very clearly you can understand by this. This is the occiput is on the left side of the maternal pelvis, then we call it the left occipital interior. If the occiput is on the right side of the maternal pelvis, then we call it the right occipital interior. If it is directly under the pubic symphysis, then we call the direct occipital anterior. Now this is a different steps of the mechanism of the labor, and I will show you the mechanism of the labor even in the tummy and the pelvis as well. So it is a very difficult to show the videos on this laptop or in these multimedias, but still you can understand something. Now the important thing in the mechanism of the, there are certain steps on the mechanism of the labor. That is, the first step is the engagement, then descent, then flexion, then internal rotation, and then extension, and then the external restitution and external rotation, and the delivery of the fetus. Now the distant engagement when the largest diameter of the fetal skull. Now this is the fetal skull, and the largest diameter of the fetal skull is the biparietal diameter. So when the largest diameter of the fetal skull enter into the maternal pelvis, then it is known as the engagement. Engagement, and that this fetus engage into the transverse diameter of the pelvic inlet. As I already told you that the transverse diameter of the maternal pelvis inlet is larger than the AP diameter, because the head is engaged into the transverse diameter. So this head will be engaged into the transverse diameter of the maternal pelvis. Now this is the engagement. Usually the head is engaged into the 36 weeks of the gestation in the primigravida, while it is engaged at the time of the labor in the multi. Usually multigravida में ये time of labor पे engage होता है, लेकिन primi में this should be engaged after 36 weeks of the gestation, but sometimes it could occur at the time of the labor as well, when the painful uterine contraction occurs. So after the engagement, when the largest diameter enter into the maternal pelvis, there is a certain descent. Now this head is in this military attitude, like this military attitude पे है, उसी में ये engage होगा. Engagement, then descent. This will further descend from this maternal inlet to the downward, and when there is a descent, then there is a certain flexion. There is a flexion of the fetal head. Flexion का मकसद है कि fetal chin will be touches to the chest. Then we call it as a full flexion. So engagement, descent, then the flexion. After the look at this, the head is in the transverse diameter. Then after this, there is an internal rotation below the ischial spine. Because of the pressure of the levator ani, the head is undergo to the rotation, and it becomes a Occipital Interior. From this occipital transfer, it becomes a Occipital Interior. Now it is a flexed and rotated head. After that, after this internal rotation, there is a crowning. Crowning का मकसद ये है कि when you are able to see the fetal head, जैसे turtle होता है ना, contraction होती नजर आता है, फिर reset हो जाता है. You can able to see the fetal head without aparting the labia. That is known as the crowning. After this, always the head is delivered in the extension. Now this is a internally rotated to the anterior, and there is a slight extension, and the head is delivered in the extension. As soon as the head is delivered in the extension, it adopt itself, it align itself with the shoulder. Shoulder enter into the maternal pelvis in the oblique or the transverse diameter. So the head is trying to align itself. So there is a slight rotation, slight. Now this is actually, there is a slight 1/8 rotation of the fetal head, that is known as the restitution. Look, this is the extension, and then just 1/8 rotation. Now after that, there is an internal rotation of the shoulder. The shoulder may come into the anterior posterior diameter of the maternal inlet, and this head will be externally rotated. The head will be in the transverse, and this will be shoulder will be enter into the AP diameter in this AP diameter. So the head try to align itself with the shoulder. Now this, look at this shoulder and the head is in alignment. हम जैसे खड़े होते हैं तो हमारे ये हेड है, ये शोल्डर है, तो हम राइट एंगल पे हमारा हेड शोल्डर के साथ होता है. तो इसी तरह से this head will be align itself with the shoulder and becomes externally rotated. Once there is an external rotation, there is a lateral flexion of the fetal head, and the anterior shoulder will be delivered, and then anterior shoulder will be delivered, and then again there is a lateral flexion, and the posterior shoulder will be delivered, and the remaining body deliver itself, and there is a little struggle the fetus will took while passing to the passage of the maternal pelvis. So these are the different steps of the mechanism of the labor. That is the engagement, descent, flexion, internal rotation, crowning, extension, external rotation, restitution, external rotation, or internal rotation of the shoulder, and the delivery of the remaining portion of the baby. You can having the such type of the station, you must learn this very clearly, because you can have the classes has been start, if for example start classes will start, I will show you in the ward as well, because you can have this station on the. Now this is a very important diagrammatically mechanism of the labor. The first is a descent, engagement, and then the descent of the head. Then this is the flexion. Look at this and look at this. The flexion, the head, the baby, whole baby is in the flex attitude. The arms are around the chest, the knees are flexed, the hips are the flexed, the head is flexed over the chin. So after the descent, there is a flexion. And then after the flexion, this is a transverse. Now look at this. This is the Occipital Interior. Now this is a transverse diameter. The transverse in the transverse diameter, this is the Occipital Interior diameter. Then there is a restitution. Restitution, as I told you, that when the head after internal rotation, the extension. Look at the extension, and then the restitution. Extension, the baby is delivered in the extension, and then the restitution when the baby's head is a turn to the one end to align itself. Then after the extension, then either the internal rotation of the shoulder or the external rotation of the fetal head. So the fetal head from this restitution may go into this occipital transverse diameter, into the transverse diameter of the outlet, while the shoulder will be entered into the AP diameter of the becomes rotated and comes into the AP diameter of the inlet. Then after there's the delivery of the baby anterior shoulder, then the delivery of the posterior shoulder. So this is all of the mechanism. Once again, we are going to descend. This is the flexion, internal rotation, crowning, extension, restitution, internal rotation of the shoulder. ये concomitantly साथ साथ होता है. जब उसकी शोल्डर की इंटरनल रोटेशन हो रही होती है तो उस वक्त एक्सटर्नल रोटेशन हो रही होती है हेड की. So the internal rotation of the shoulder or external rotation of the head, and the delivery of the anterior shoulder, delivery of the posterior shoulder. This is all about the mechanism of the labor. Again, the cardinal movement, this shows the head is delivered by the extension, as I told you, and then there is after the extension, there is a restitution. Head is just turned to one head, and then there is an external rotation, so the head is in the transverse diameter after delivering, aligning itself with the shoulder. This is the crowning, and this is the head is delivered by the restitution, which we discussed. And what is our aim? Our aim is to deliver the normal healthy child, to anticipate, recognize, and treat the potential abnormal condition before the significant hazards develop for the mother or the fetus. What is the principles? Principle ये है कि you must diagnose the labor, whether the patient is in the labor or not. How will you monitor the progress of the labor? That is the maintenance of the partogram, ensuring the maternal well-being, ensuring the fetal well-being. ये हमारे principles हैं while you are conducting to the normal labor. Now the management of the normal labor, that is the assessment, preparation, partogram. This is the now assessment. How will you do the assessment of the labor? How will you, as soon as the patient come into the labor ward, this is very important that you must take the history of the patient. In the history, you must take the biodata of the patient, what is the name of the patient, husband's name, age, what is the parity. Parity means we have discussed. Parity means number of the female to deliver the alive or the dead babies. Gravida means number of the uterus to become gravid. How many times the uterus get gravid, irrespective of the outcome. आउटकम कुछ भी हो, लेकिन ये कि कितनी मर्तबा वो यूटस ग्रेविड हुआ है तो उसको ग्रेविडा कहेंगे। और ग्रेविडिटी में भी दैट फुल टर्म भी हो सकती है, प्री टर्म भी हो सकती है, उसमें अबॉर्शंस भी आ जाएंगे। While the parity is the outcome, which is after the 28 weeks of the gestation, and then plus the miscarriages. जितने भी miscarriages हुए उसको हम प्लस में कर देंगे। बाकी parity वो होती है जो 28 weeks के बाद जितने भी outcome हुए उसको हम parity कहेंगे। So while you are taking the history of the patient, must ask about the parity, gravidity, parity of the patient, how much gravida she is, how much para she is, what was the mode of delivery, whether it was a normal, it was a cesarean section, whether the labor, this pregnancy was induced, it was a spontaneous conception, whether she has the antenatal checkup, how she confirmed her pregnancy, what is her last menstrual period, did she have any ultrasound, first trimester ultrasound, that is a dating ultrasound, and how she confirmed her pregnancy either by the pregnancy test, by examination of by the obstetrician, or by the history, by the symptomatology, or she did the urine for pregnancy test, or she have the ultrasound examination. If she has a record, it's a very important to review the record. But if she didn't have any record, then you must take the complete history of the patient. Complete history include the history of the presenting complaint, history of the presenting illness, the past obstetrical history, past medical and surgical history, the family history, the social history, the personal history. All the component of the history will be come into in the obstetrical history as well. Then after the past obstetrical history is very important because the management of the patient of the current history will depend upon the past history. For example, a patient having the previous missteps, none alive, some IUDs, some neonatal death, some preterm babies, but she has no alive issue, then the mode of delivery and the duration will be depend upon this previous obstetrical. You are not going to give the long trial of the labor in these patients because this will compromise the baby. So it's a very important to it. A patient is also anxious, so this is a very important. If, for example, patient having the previous 2 cesarean section, then you will decide for the cesarean section. We will not going to give the trial of the labor. But if the patient having the past history of the normal easy vaginal delivery, you can easily give the. For example, if the patient having the primary gravida, but she have the no any adverse event into throughout her antenatal period, and she has a cephalic presentation, she has the adequate pelvis, then you can give the normal trial of the labor. If there is a no contraindication, so by the history, you can at that moment you can decide for the mode of the delivery and the route of the delivery. Then the examination, no doubt in the examination you have the look on the general appearance of the patient, the paleness, the edema, any abdominal examination. You must look for the abdominal scar in the previous cesarean section or the myomectomy or the laparotomy scar. Then you must take the pulse, the blood pressure, the respiratory rate, the temperature. You must auscultate the heart and lung for any pathology. Then must do the abdominal examination. The abdominal examination, on the abdominal examination, there's a Leopold's manual that is written in the 10 teacher. You have to look on this manuals different, in which we having the different grips, the fundal grip, the lateral grip, the pollic grip, and the pelvic grip. 4 grips there are. The fundal grip, we have to assess the fundus. Where is the fundus? Either it is at the xiphisternum or below the xiphisternum, and we measure it, the height of fundus by the measuring tape, and that is from the upper border of the pubic symphysis up to the xiphisternum, or the height of fundus. So we measure the 1 centimeter is equal to 1 week. So by this we assess that how much weeks in the gestation is. Then the lateral palpation, for the lateral grip or lateral palpation, in the lateral grip we assess the lie of the fetus, whether it is a lying longitudinally, it is a lying obliquely, it is lying transversely. and on which side the fetal bag is lying, on which side the fetal small parts are lying, and no doubt the amount of the liquor amni, fetal movement, uterine contraction. Then the pelvic grip. In the pelvic grip, we assess the which part of the fetus is occupying in the pelvis. Either it is a cephalic or it is a breech. And because with the longitudinal lie, the baby may be presenting with either the breech or with the cephalic presentation. So we assess the which part is, and then the colic grip, in which we assess how much head is fifth is palpable above the pelvic rim. If whole of the head is palpable above the pelvic rim, then we call it the 5 by 5th palpable. If some part of the head is enter into the maternal pelvis, we call it the 4 by 5th palpable. If the major portion enter into the 3 by 5th or the 2 by 5th palpable, if it is not palpable, we call it the 1 by 5th or the 0 by 5th palpable. 0 by 5th or 1 by 5th is a fully engaged head. At the same moment, by abdominal examination, we evaluate for the uterine contraction, how much there are uterine contraction, what is the frequency of the uterine contraction, what is the duration of the uterine contraction. For the normal labor, the good uterine contraction, we can see that there must be at least 3 to 4 uterine contraction, and each contraction should be lasting for the 40 seconds. Then we call it the good uterine contraction, and they should be coordinated. One contraction should occur after other contraction, one other contraction. So it leads 10 in 10 minutes duration. There should be the 4 uterine contraction, coordinated and regular uterine contraction. Then we listen the fetal heart sounds by either you, if you have the facility for the CTG, you can do the CTG, apply the belt over the maternal abdomen and do the CTG. If you do not have the CTG machine, then you can sonicate or the Pinard spectroscope. You can listen by the stethoscope, by the Pinard spectroscope, by the sonicate. So normal fetal heart sounds are 110 by the 150 beats per minute. If more than 150, then we call the tachycardia. If less than 110, we call the bradycardia. And this regularity and rhythm is also important. Now this is the 5th palpation of the fetal maternal abdominal palpation for the fetal head. Now in first picture it is a 5 by 5th palpable. In the second is just enter into the pelvis, so it is a 4 by 5th palpable. Now in 3 by 5th palpable, you can able still your finger can be able to palpate this fetal head, while 2 by 5th just portion of the fetal head is palpable. Otherwise, the largest portion enter into the maternal pelvis. In 1 by 5th and 0 by 5th, you are not able to palpate the fetal head. Then you are going to do the vaginal examination, but there is a one thing which is a very important, very, very important. If the patient come to you with a history of the heavy vaginal bleeding, or there is a gush of fluid, or there is a leaking, then it's a better not to do the vaginal examination. Instead of doing this vaginal examination, you must do the sterile speculum examination. So for the vaginal examination, we confirm along with the uterine contraction, whether the patient, what are the changes in the cervix, whether the patient is in the true labor, or it is a false labor. So by the for vaginal examination, we assess the presenting part, what is the presenting part, and what is the station, and what is the position of the presenting part. I already told you the position that this is the occipit. Either this occipit is anterior or occipit is a posterior. Either it is a right occipito anterior or left occipito anterior, or it is a direct occipito anterior. And at which station is the head is. So these are the landmark, that is the ischial spine. When the head is at the ischial spine, we call it the 0 station. All the portion of the head which is above this ischial spine is come into the plus minus, while the portion of the head which come downward is in the plus. So if the whole head is above this ischial spine, we call it a -3 station. But if it is a downward, either the +1 station or the -2 station. plus 2 or minus 1 plus 3 is a 0 station. So either 0 station plus 1 station plus from the 0 this may come downward plus still downward plus 2 still downward plus 3 is 8 means it is in the perineum. Again the same diagram, that is the still spine is a 0 station. The fully free head is the 5 by 5th is the minus 3 station. By fully head which is at the perineum, we call it the plus 3, or when there is a crowning we call it the plus 3. Now again these are the position as we discussed already, right occipital interior, left occipital. Then while doing the vaginal examination, this is the you are going to do the vagina. This is the vagina. This finger are in the cervix. These are the cervix. These are the cervical margin. So this cervix is dilated. This is not a correct position while you are introducing your finger inside, not inside, just in the margin of the cervix. So you assess the, sorry, not in the margin but inside the cervical canal. So you can correctly assess the dilatation of the cervix. Sorry, this is the incorrect position. Not inside, this is the margin. By in the margin, we assess the dilatation of the cervix. So this is the for the after the this vaginal examination, we assess the on the vaginal exam apart from the consistency, position, dilatation, and the effacement of the cervix. We assess whether the membrane are intact or not. The membrane are intact or not is a very important, while if the membrane are ruptured at the same time, so you are going to do the vaginal examination. If the water break, then it's a very important to exclude the prolapse of the cord, because sometimes if the presenting part is not engaged properly, then it is a free, then the cord may be come out, and as soon as the membrane rupture, the cord may be dropped down. So this is again obstetrical emergency. Now look at this cervix. The cervix is also tightly closed, and the cervix is still not effaced. So 0 effacement. Now there is a certain, though there is no still dilatation, but the length of the cervix becomes short. So we call it the 30% effect. While you cannot be able to see, look at this, full dilatation with a full effacement. Here is a full effacement because the cervix length is small, but still there is no dilatation. So in the primary gravida, like similarly, this again full effacement but no dilatation. This is effacement with 3-4 centimeter dilatation. So in the primary gravida, initially there is an effacement followed by the dilatation. While in the multigravida, the first dilatation occurs and then there is an effacement. Now after that, we at the same time we will do the pelvimetry assessment of the adequacy of the pelvis, whether the pelvis is adequate or not. So this is the diagonal conjugate. While you introducing your hand inside and your finger reaches to the sacral promontory, this diameter should be 10 centimeter. If it is a less than 10 centimeters, means the AP diameter of the inlet is shorter and the patient is not going to the. So far the end, while you are going to in the this pelvimetry, we assess the pelvic inlet, we assess the cavity, we assess the outlet. For the inlet, we assess the diagonal conjugate, that is the AP diameter, that is it should be 10 centimeter, like this picture shows that your fingers are reaches to the sacral promontory and this but on the pubic symphysis, lower portion of the pubic symphysis, then it means it is the 10 centimeter. For the inlet, the landmarks for the adequacy or the sacral promontory should not be reachable. Like this, we introduce our finger and assess the sacral promontory. It should not be reachable. It should not be prominent. So it should not be convex. Then this is the hollow of the sacrum. The hollow of the sacrum should be curved. It should not be straight. For the adequacy of the pelvis, for the gynaecoid pelvis, the hollow of the sacrum should be concave. It should not be straight like this. It should be concave like this. Then and the cavity, for the cavity, there should be we assess the ischial spine distance between the ischial spine by measuring the three fingers, which is the, should occupy three fingers is the ischio, the sacral ligament occupy the three finger, we call it's the distance between the ischial spine is a 10 centimeter. Excellent. Then yes. So this is the fingers which show that the three finger occupy in the sacrospinous ligament. Then we call that this diameter, the diameter between the two ischial spine is a 10 centimeter, more than 10 centimeter, and this means the cavity is adequate. Then we assess this pelvic outlet by the foreknuckle. If the foreknuckle are occupied in between the two ischial tuberosity, then we call the outlet is adequate. And the subpubic angle, it should be wide, like 90, or so should be more than this. Then it will be occupy the four knuckles after this. So this should be like this wide. It should not be this obtuse. This should be obtuse. It should not be narrow like this. So this is the outlet. So in outlet, we assess the subpubic angle. We assess the distance between the two ischial tuberosities. That has show us the adequacy of the pelvis. So this is already I told you that do not do the vaginal examination if the patient having the vaginal bleeding, because that there may be the placenta previa. Unless you exclude the placenta previa by the ultrasound examination, then you can do that. Instead, you can do the sterile specular examination if there is a rupture of the membrane or the patient is not in the labor. By assessing which patient should require the hospitalization, those patients who are in the active labor, those patients who have the regular painful uterine contraction, those patients having the cervical dilatation more than 3 centimeter, are patient in the active phase, not the labor, 4 centimeter rather. The patient is the more than 4 centimeter dilation, means active phase of the first stage of the labor. Because as soon as the patient remain into the labor ward, she becomes more anxious. There may be that. It's better to keep the patient into the home while the actual labor is started. She should come into the ward. What investigation will you do in the? There is at the same moment, if the patient come to you after taking the history, after taking and doing the examination, and then you send certain investigation like blood CBC, complete blood count. If the patient having already, if she is a booked case, then you review the record and you assess how long she has how much time has been passed to have such type of the investigation. So the blood CPC, the random blood sugar, blood grouping and cross matching if the patient required, and the viral marker like hepatitis B, hepatitis C, the HIV, and urine examination is very important for the protein, for the sugar, for the ketone, because these things is very important, because the hypertensive patient may have the proteinuria, the diabetic patient may have the sugar and the ketones. To excluding it. But if the patient already having this investigation, there is no need of the repetition of that. Now the bowel preparation, there is no need of the bowel preparation for the patient. But if the patient, there is no need of giving the enema to the patient, the bowel preparation. But if the patient having the constipation and didn't move the bowel for the last 24 hours, then you can give the enema to empty the bowel. However, there is a very important to empty the bladder. This is too early. This is a very important, because the full bladder may inhibit the uterine contraction and will be interfere with the engagement of the head. So it's a very important that and moreover you have to measure the urine output as well. So it's a very important to ask the patient to pass the urine every 2 hours. Regarding the nutrition, what nutrition the patient should have? Is there is a delay in this food in the stomach, so you are not supposed to give the full diet to the patient. However, the patient can take the juices, the small amount of the fluid, the water, the juices, the cold drink, the ice creams, and to moisten the lips and all these things. So the sex is, patient must be adequately hydrated. So this can be in the form of the these juices and the fluids. What about the perineal shaving? It's not necessary, because if at the time of the delivery, if you are going to do this perineal shaving, this will causes the infection, increase the rate of the infection. Should we do the routine rupture of the membrane, artificial rupture of the membrane? Not before it is normal time of the rupture of the membrane is the second stage of the labor. But if you think that there is an unnecessary delay of the labor, then you can rupture in a sterile condition. Aseptic precautions should be taken, because it will decrease the time for the delivery. What should be the position of the patient? In which position patient should be? Either she has the lying, it depend upon the comfortable as the patient's wishes. If she is comfortable in the lying position, she can lie. If she is comfortable in walking, she can walk around. If she is comfortable in the left lateral, right lateral, in the squatting position, whatever the position she can adopt, she can have. There is no contraindication in any kind of position. About the pain relief, what should be how the pain should be relieved of the patient? There are the multiple, this depend upon the choice, again the choice of the patient. Some patients do not want to, they have the, some have the low threshold, some have the good threshold for the pain. So depend, it's individualized according to the patient. You can give the injectable like the pethidine intramuscularly, orally, or you can give by the inhalation analgesia, Antonox, or you can give the epidural analgesia and you can top it. Epidural analgesia, there is a one advantage of giving the epidural analgesia, that at any time if you require any type of the instrumental vaginal delivery or operative vaginal delivery, or you try and require the cesarean section, you can top up this. Otherwise, the epidural analgesia, the disadvantage of epidural analgesia is that it prolongs the second stage of the labor, and there is more chances of the operative vaginal delivery as compared to the patient who didn't have the epidural analgesia and analgesia. Now, this is a very important, the monitoring of the progress of the labor. Once the labor has been established, all the events of the labor should be monitored on the partogram. And the partogram is the graphical record of the mother and the fetus on the paper during the labor. So this is known as the partogram. Partogram shows us the well-being of the fetus, the well-being of the mother, the progress of the. वो एक पेपर होगा, उसको देख के ही आप बताएंगे कि ये लेबर नॉर्मल में गया है या इसमें कोई प्रॉब्लम है. So we will discuss this partogram tomorrow, because still there is a large lecture left behind. We will discuss it tomorrow. Okay, thank you very much. Now, if you people have any question, you can ask. Is there any question? Participants, are you listening or sleeping? Hello? Hello?
No, ma'am, we are listening.
You are listening. Is there any question? Did you understand the labor? Hello?
Yes, ma'am. Yes, ma'am.
Is there any question?
No, ma'am. No any question.
No any question? Are you all understand the labor? This is a very difficult. I think this is a very difficult, not so much easy.
Almost, ma'am.
Okay. So hopefully you all understood the lecture. We will continue this in the tomorrow, the partogram and the CTG. Okay?
Okay, ma'am.